I am in Unit 10, and this is the end of my journey. So I'm so happy to present my last journal for the class MN662 today. To begin, I had a good time in clinical. So my preceptor is very professional and very instructive, deliver informations, help us expose to the clients. We have the chance to come from low to high from the beginning. She's very patient. She knows her content, her information. She really goes by the core curriculum for to deliver what the school expected little by little. She understands that we don't know everything at once, so she takes time to go step by step every day, every week, in order for us to understand. But I'm talking for me, so that's the way I feel. So the first week was for, of course, MN6621. So it was psychotherapy field for the focus on psychotherapy to help us cope with the clinicals, and also to see patients overcome the challenge. So in order for us to understand, she let us follow her interview, or she does with the patients, or she collect the data, and how to listen to the patients, really to focus on get the specific information. And that's all she said in the first week to concentrate on. So nothing else. We wasn't concentrate on diagnose the patients and anything more than that. So we collect the information. We discussed, of course, like depression patients. We got the DSM-5, we got the GAD, we went over the questionnaire. So that was we focus on. I have patients that came with anxiety, with depression. So I saw those patients a lot in the beginnings. I remember that was the beginning of winter. A lot of winter depression, a lot of people that get falling back again on depressions, and a lot of anxiety. People got parents that sick and get anxious. So we got all type of those. We also see schizophrenia patients in week 1, but all we do in week 1 was like she focused on us getting the information. Of course, she helped us after that to the diagnosis of the patient in order for us to get her encounters. She said, "This is what I will do. This is what I will do." She didn't let us decide at that point or and decided anything else. So in week 2, 6622, she goes gradually going into the Molly, the diagnosis. What do we think we can diagnose these patients if it's in. So we went to the diagnosis, to the DSM-5 to find out about the differentials diagnosis and the definitive diagnosis. So this is a process like very culturally sensitive. Also, she tailored the individual need, and she taught us how to determine per culture which diagnosis the patient is, and by collecting the data and those things. In week 3, we try kind of organizing the diagnostic testing based on the history of the patient for the individuals, for families, we have adolescent. I remember in week 3 I have adolescents. I have an adolescent. I spoke in my last journals that came, and she was very challenged with her family. She was taking drugs because she find that she couldn't fit with her family anymore. She went outside and she get drugs. She get drugs with candy drugs, and she ended up having seizures. She went to the hospital, and we went based on the lifespan of this type of patient, acute and chronic complex health disorder. And she was having like a coping mechanism difficulty. Those are things like was mentioning on week 3. So, and of course she's a very complex anxiety, depression disorder, bipolar patient. So in week 4, I mean 664, we go more on gender culturally. I remember we got a transgender patients also that's got difficulty acceptance with the family. And then we went also helping the patients, finding herself the way of coping with the situations of acceptance and identity, or ethically. So her parents was spiritually against that situation. So this is a role to cope with her family through these things. And she was referred also to a LGBT community, so in order for her to find her identity. And now on CBT therapy, so we start using gradually CBT therapy. The preceptor start telling us also when to refer the patient. Sometimes she found some patients who really doesn't fit for her as a therapist. She referred them after the first visit to psychotherapy, and then she give appointment like for 2 months. If this persists like 2 months, 4 months, the same problem, now we can figure about medications. But those patients, a lot of patients like identity role, so more of them ethic patients, spirituals, like a conflict between family, gender conflict, we refer right away. And she started involving us, like interviewing the patients by herself, and then she correcting us after to see if we can direct an interview. That wasn't easy for the first time, but I got it. So jumping in week 5, 66 to 5. So we are increasing in knowledge about medications, how to send prescriptions, which medication fit. We work a lot on anti-anxiety disorder. We work a lot on antidepressants. We work a lot on antipsychotic medications. We got to go to database. Oh my god, I don't remember the one that she used to see. I don't remember quite the database she used to check what was the last time the patients took substance abuse. So because we got to be careful about substance abuse, because see week 5 I saw a lot of patients also call for drugs, and they just like shopping around for drugs. So and she taught us how to check, how to verify. This is important to avoid drug abuse. And we also send medications, the medication for low cost medications for Medicare, Medicaid, and medications with low side effect. For instance, Geodon wasn't the drug of choice drugs like antipsychotic, because before you prescribe Jordan, you gotta make sure that we do an EKG, and also which drug the best drug of choice we had, like for anti-anxiety, that was Buspar. My preceptor prescribed that a lot. That's her best drugs. Citalopram, SSRI, citalopram, and Wellbutrin for to avoid weight gain. So we really like selective, like the kind of drugs like that patient respond the most, and respond faster but cheaper. Okay, then jobs on to 665 week 6. That's when we start really apply a lot of psychotherapy, CBT therapy, difference between DBT therapy. My preceptor used this CBT therapy a lot. Or we start like having or answering open-ended questions to investigate on patients' abuse, on patients' status. We practice those. And week 7, so we are progressing. I see patient by myself and then give report to my preceptor, and using the most systematic approach. And so he was a couple of them. We work in small groups and then dispute cases, and then report to the preceptor. So we get the history. I get the history by myself, and I can begin develop a mental health assessment by myself. I can develop my diagnosis by myself, and I will know which medication to prescribe, which labs to do, when to do the labs, CBC, comp, AKG, thyroid, when to do those labs, when to check the result, when to refer back to the PCP, if the PCP put the patients on psych medications, so when to contact the medications, the PCP, I mean. So after on week 9, I did more progress. After developing a treatment plan, I can begin arrange my diagnostic testing, and I can use it to confirm a rule out of diagnosis, to help me determine the best course of treatment and track progress, give appointment follow-up. So some patients just need a follow-up for 3 months. And some patients just call after 1 week after medications to give report how do they feel this week. And now week 10, this is the week 10. I only spent 3 hours in week 10 because I did complete almost my hours. So that was my debriefing, evaluation of my preceptor. This is a very good site. My preceptor have a good database reference that she gave us in order to additional reference that she used, research. She used evidence-based practice. She's very professional. She deliver information. She let us have hand-on care. So she let us have hand-on care, and also she's teach us about patient safety, the most important in the delivery of mental health care, and with no exception. So safety standard is important. So she gave us advice in practice, best practice. The quality of care for the client is extremely important. And the HPM, HPPM, HNP role, its own quality indicator. So it's good to practice, but best practice is always the most important things, especially with this population. So I was having a good 10 weeks clinicals, and I get satisfied with the course. And Professor Joshua, also thank you for your PowerPoints, your interactions, your interview during the PowerPoint. I felt like very instructive. Thank you so very much. I look forward to see you again, maybe in another clinical. You never know. And that was a good season, a good season. And thank you so much. And I wish you a happy holiday. Thank you.